It's really nice to be with you guys. I appreciate, as a clinician, I appreciate your time and really respect what you're doing. In my role as Chief Clinical Officer, I have to do a bit of a commercial for the organization. We are 1,600 employees across 3 countries and 9 locations in the U.S. One of the things that I think positions us a little bit differently than a lot of our colleague providers is we're fairly technologically integrated. We have 2 transcranial stimulation programs starting up in California. We are treating adolescent eating disorders, and we just started a transgender adolescent program in San Diego as well. All of our sites are neurofeedback equipped. So we try to blend technology with traditional psychotherapy and drug and alcohol interventions. My little commercial. But I'm trained as a psychologist, and I love doing therapy. And what I want us to do for a second, just for the remaining time together, is just take off our administrative hats and forget that we run things or supervise things and just go back to our roots, to what brought us into this field. And for many of us who are clinicians, and I ask you, just let's all be clinicians for the rest of our time together. When you look at a hypothesis, I got to say, I think most of us on like a Myers-Briggs type scale are probably highly intuitive. But treatment is more than intuition, okay? It's based on clinical research. It has to be. It has to be evidence-based. Now, the evidence sometimes equivocates, understandable, but that's like the major professor told us, know why you're doing what you're doing. And I tell my residents that all the time. I may be right, you may be right, but tell me what your thought process is. Why are you going in that direction? It can't just be because I have a good hunch. The working hypothesis has to be based on the assessment of the client's capacity. One of the things we're doing at Sovereign is we're slowing down the entry into treatment, because what we're finding is we get patients, 5, 6, 7 failed treatments, they hit us. And we ask for records, and there are no records. They've spent their life basically in treatment, and nobody has done a diagnostic workup. So we're trying to slow that process down so that we can get capacity. Now, this is a huge problem. The research says by about year 12 of chronic alcohol abuse, the subcortical functioning, in addition to the temporal lobe functioning, starts to decline. So think about your folks you have in your office, in your program, who started drinking at 16. They're now 28. Well, that's good 12 years of chronic alcohol use where some of their reasoning ability, some of their functioning starts to look like pre-dementia. And of course, what do? We try to treat these folks whose cognitive capacity is less than their non-drinking peers. We treat them with cognitive behavioral therapy, which of course plays into their weakness. So we ask them, can't you anticipate the consequences of what you're doing? Well, no. That's part of what their cognitive deficits are occurring right now, right? Your hypothesis needs to be include the assessment and the diagnosis. Now, the thing that we have to really be aware of is our experience and expertise. Your license and your credential is very important. It's good. Congratulations. Expertise is really key, and experience is really key in informing our hypothesis. We can't underestimate that, okay? This is one of the few industries, for those of you who are very young, this is one of the few industries where age is your friend, okay? Nobody wants to go into family therapy and be told by a 24-year-old how to handle their marriage. Nobody wants that. But, those of us who are older, it's pretty cool. You get an automatic Freudian, respect almost, right? So I say this because there are times when in our industry we can run into the hierarchy of who's better, and no. Experience is really important in our field and helps to inform our hypothesis. Now, I'm clearly psychodynamically trained, so for me, countertransference and transference are very, very important. We learn a lot And our hypothesis starts to change based on what's happening in the four walls of the therapy. Okay? So this is really the overview of how we generate hypotheses. Think about when you are in your treatment, in your therapy, and you're doing your treatment planning. All right? Now, think about what you're looking at. You're making an assessment, just by virtue of the person showing up in your office, that there needs to be some kind of a quality of life improvement. They need to learn more effective skills. Their relationships are terrible. They need to improve those. They need to stop doing these behaviors and learn these other behaviors. And think about all the things you write in a treatment plan. At the end of the day, all of these and any nuanced versions that you have basically are change. You are saying there needs to be a change. Now, sometimes your client, your patient will agree with you and self-present, and they'll be psyched that you're there to work with them to change. Other times, they're very reluctant. They're either sentenced to you or they're coerced or whatever. But what's important here is now you are a change agent. Like it or not, because your treatment plan doesn't say, hey, Joe, keep on smoking crack. It's working for you. That's not what your treatment plan says, right? Your treatment plan is, how are you going to change that behavior, right? So like it or not, you are now an agent of change, the way it is. So now you have to start to say, what do you believe about change? There is definitely an age curve on how older versus younger people see change. So those of us who are older start to realize that change is maybe a little bit more gradual, maybe a little bit more circumscribed. Persons who are younger see the world as their oyster. One of the things that we decided to do personally is 5 months ago, just move. So we just said, let's change. Let's just do a change. And we moved from the East Coast to California. And just said, hey, why change? Well, change because one of the things we know is change enhances cognitive functioning because you have to learn, your brain makes new circuits. So yeah, we'll give that a whirl. But all of us as therapists, we are agents of change. What is yours, mine, our hypothesis about change? Do you think people can change? Do you believe that there is an ability, innate or learned behavior to change? So this is important because in the therapy, I know we've all had that experience where we felt, oh my God, I wish I had asked that question. But you didn't. You asked another question and the patient took you in a different direction and you were kind of bummed out. You felt like you missed that opportunity. It happens to all of us, right? But when we start to think about change, it's going to relate directly to why did you ask a specific question? You need to know why you asked that question and not this one. Because the answer is going to take you in a direction, right? You need to know what is your hypothesis behind assigning a particular homework task, okay? Why do you just shut down when somebody says something? Those of us who are psychodynamically trained often will just be very silent and wait to see what the reaction is, okay? Why? Why do people trained that way believe that silence and the reaction to silence is of value? Again, no right answer, no wrong answer. It's the hypothesis that's generating the behavior on the therapist's part. All right? You're going to need to come up with your hypothesis about how people change maladaptive behavior because your treatment plan is full of maladaptive behaviors. So now you've got to figure out, oh boy, okay, I got 3 of them. How are they going to change these behaviors? How do I believe people change? And so you ask the question, an older person, can a tiger change its stripes? And I just put I needed a color slide, so I said, okay, we'll just do different variations of tigers, but these are all different, stripes. Can a tiger change its stripes? Younger people tend to say, yeah. Older people, from experience, say, well, maybe not so much. Is personality trait or state? You can get into all of that discussion, right? But one of the things you want to do, I believe, is go into your own experience. Think about how this is why experience is important, how have you navigated change? If you don't ask yourself that question, it will come out subconsciously, psychodynamics belief, so it's good to kind of bring it to the forefront. Think about the changes that you have made. from role, student to professional, single to married, couple to parents. How have you handled the change? It's your experience, because like it or not, you're going to bring that. That's the counter-transference that you bring into the therapy. If you're not aware of it, it's going to surface. It definitely does. So in the psychodynamic training, you begin to unmask your own experience. All right? Now, I just want to take us through what we learned in school, the different developmental theories of change. You've got the biological model. You've got a psychological model, which is great. Why can't you take responsibility for your own actions? And the kid says, I blame my upbringing. Okay? And then, of course, what we were mostly learned, probably most of us learned nature and nurture, a little bit of both. Sometimes that seems like a cop-out, but it's that whole genotype, phenotype. There's environmental influences and there are biological influences. That's going to be important for drug and alcohol, because that's going to start to underpin where the disease model came from. All right? Now, probably the most studied and most intuitive, and for my money, the most valuable theory on change comes from social learning. Okay? And this is very well studied. It's the Bandura work. So this is really important, because what social learning theory says is if an observer values the action of another person, the observer is likely to change. And what are the characteristics of that valued person? So they've got to be perceived as attractive, as strong, as all the qualities that the observer would like to have. Okay, and there's a lot of research on this. Now, this becomes important because in the therapy, you are, well, you don't really look like him, but you are him. You are Bandura. All right? Your patient's coming in to your office. Like it or not, you're an agent of change, and like it or not, you're either going to be an effective model or an undesired model. And we've all had the patient we didn't click with, who you just had to transfer to a colleague because it just wasn't working. The transference just wasn't there. Okay? But this is important to know that, you need to understand this is what's happening when you show up for work. You are this. Okay? It's not like you walked in and said, hey, I'm your social learning role model. You are automatically that. Just the way it works. Okay? Now we have the behavioral models of change. This is really interesting because those of us who work in facilities, this goes back to the Skinnerian and the operant stuff, but you are the mother here. Okay? You're the mother model where the patient comes into your office and has a reaction to you in your role. We call it white coat hypertension when we go to see the doctor. Okay? But you're the same thing. You've seen this where they come in and they're like, oh God, I got to talk to him. Oh, this is going to be a waste of my hour. Okay? That's the response to you as a stimulus. You didn't ask to be this, and I'm not saying you're doing anything to be it. You are it. It's how it is. That's how it works. You are a stimulus to them. You need to be aware of this. Okay? Not saying you can do much about it, but to be aware that you are the role model. Okay, perhaps. You are a stimulus. Okay? This is what happens. This is really bad. We don't want this to be part of therapy, I don't think, because it doesn't really speak to the transference. But, this could happen. I'm not a big fan of, not a real big fan of the behavioral models of treatment for adults. We can talk about that, but I don't know that's really the preferred method, at least not for me. All right? So in behavior therapy, how many times, and this is a little bit new to me being out in California. Well, California is just very different from the East. There's like anything goes out here, it seems. But I've never heard so many patients say, I can't go to this group, it triggers me. I mean, the whole state's being triggered by something. I'm like, wow, what's all that about? But that's classical conditioning. I walk into this setting and boom. We have our facility in El Paso. I think it's pretty nice. It's really nice, but it's like the first floor of a nursing home. All right, but it's nice. It's not like a dump or anything like that. But we have somebody who's like, I can't stay here. It triggers my inpatient stay. I'm like, dude, are you serious? You stayed in a hospital like this? Why'd you leave? I mean, it looks really nice. But again, trigger. So hey, it's classical conditioning. This is going to happen. Some folks will be triggered by you, okay? By your affect, your dress, by this building. I mean, this building is stunning to me. Again, coming from urban Philadelphia, this is like a resort. But some people get triggered by this, all right? And then you have operant conditioning, which I really don't think works. Operant conditioning is a very short-term motivator. It's the event occurs, and then there's a consequence, either positive or negative. And we know that fear and negative are very short-term change agents. All right. This is about dissonance. Now, I like this because cognitive dissonance, and this is really important in the therapy, cognitive dissonance is when you throw a curveball at the patient, all right? And you are challenging their distortion. Addicts, as you guys know, are replete with distortions. They distort perception, they distort their responses, they distort interpretation, they just distort constantly. They make up stuff, they justify, rationalize, and anything that you can do to disrupt that distortion is really, it just throws a new circuit in the brain. It interrupts it. So I had a guy in Philly who was a sex addict, a drug addict, and an alcoholic. And it was like whack-a-mole. Which one is going to emerge in the therapy today? And I remember asking him, dude, you got 3 of the big 4. Why aren't you a food addict? And he said to me, because if I overeat, I'll get fat and I won't be able to have sex. I said, okay, so that's cool. That was his justification. That was his distortion, in action. But the thing that's important here is in cognitive approaches, you throw that curveball, you introduce something different, and you don't tell them, I think you should. You always ask them, how's this working for you? You've been smoking crack for 12 years, and you've been sleeping in a box. Well, what do you think about this? So the issue with when you throw assimilation means I take new information in that you just gave me, and I try to expand my repertoire, my behavioral repertoire, or my self-appraisal. And that's where you have a problem. Because most of the folks who come to us have histories of really poor self-esteem. They've had 12, 13, 15, 20 years of continual negative feedback from individual people, but mostly from their own assessment of themselves. They don't see themselves as efficacious. They just don't, they haven't had the experience. They've gotten very little self-promotion and very little support and positive feedback. So what they're used to, if you look at the brain, the depression loop and the addiction loop almost go on top of each other. Because at the end of the day, when you ask them, well, geez, how did you feel after this bender or whatever? Most of the times they'll tell you they feel like crap. And then you say to them, well, God, tell me your thought process between going out of your way to feel so bad. Why would you do that? Why would you do that? And it's really interesting to kind of engage that process because somewhere in there is a distortion that if I do this, I'll feel good, but they're able to say, but I don't feel good after it's all over. So you've got to kind of work that. That's where you would give them new information and hopefully they'll start to accommodate. But I'm going to tell you that until they start to see themselves as powerful, it's really hard. You've really got to, in DBT, you do spend time with having a person go through their history at the times when they were successful. And some folks can't, they haven't had a successful experience since maybe the second grade, or the third grade. And they've had 15, 20 years of just negative feedback. I mean, imagine that. We've all been in arguments with people we love. Can you imagine a steady diet of years and years of negative feedback? That's just horrible, So that's what often what comes to us. Now, if you guys were students of mine, we would go through this little exercise. And I would say to you, do you believe that people change when they hit bottom, the old kind of mentality? All right, and I would say to you, okay, so tell me what you're going to do. How will your treatment plan reflect that belief? I may not agree with this, but that's not my issue here. Tell me what you believe, okay? If you believe that people change from a social learning perspective when they're in a loving, supporting, Winnicott, Bowlby, attachment theory, if you believe that, okay, what are you going to do? What's your intervention going to look like, right? Because some of us believe that, and I'm not saying it's right, I'm not saying it's wrong, but some of you believe that. Some of you believe that your milieu and your therapy needs to be this. And you may be with a colleague who thinks that. Right? So again, it's a matter of, let's talk about what has led you to this conclusion and how will your treatment reflect that. Insight, that's like the grandfather, right, of therapy. That's the Freudian model. Insight creates behavior change. Perhaps, perhaps not. Maybe it's a combination of those. If you believe that people change when they learn incompatible behaviors, perhaps they change through punishment or fear. If you're hanging on to this one, with all due respect, probably get rid of it, because there's not a lot of research for this one. Maybe, and we see this. You guys may know colleagues. You may be this way. You got sober. You manned up, and you just did it, and they can do it too. Well, no, it doesn't work that way. It really doesn't. The only reason why I criticize this one is because the research just doesn't support it. Now, people change when there's a pro-social behavior that's incompatible with the negative behavior. So what I ask people to do when I was working with alcoholics, I would say, okay, where's your bar? Where do you go? All right? And I would say to them, I want you to drive past it. Can you drive past it? I don't care if you go in later, but let's just drive past it and monitor your body. What is your body doing? Is your heart rate? Are you getting flushed? Can you feel the energy, the anxiety, the anticipatory anxiety? And then I want you to go past it. Now, when you go past it, I want you to give yourself, a positive self-statement. Hey, I beat it. I did it. Just to kind of get them to see, can self-praise replace the high and the rush, mostly the anticipatory rush of going into alcohol? Do any of you guys deal with sex addicts? Sex addicts, this is like huge for them. 90%, well, 90, a large portion of sex addiction is about the rush, about the anticipatory. I'm going to find it, I'm going to find it, I'm going to find it. And the act itself oftentimes can't even be completed because it's just not really what they were looking for. It was more the rush. So I do think this is an interesting one. This is what we try to do when we try to teach people a new repertoire of behaviors. All right? But if you believe this, which I do believe this, but then this goes directly back to the self-efficacy discussion, where how am I teaching somebody whose prefrontal cortex and subcortical functioning is starting to decline, and they never learned anything, they can barely spell their name in many cases, they got no skills. I mean, this is a challenge, okay? I mean, this is what we're looking at. All right, addiction. Segue real quick. What causes addiction? All right, if anybody tells you there's one answer to that, they're lying. There's no one answer. Definitely there's genetic predispositions, absolutely. There's environmental, social learning contributions as well. There is some evidence that either real or perceived trauma contributes to compulsive behaviors, addictions of different sorts, process addictions and substance addictions. All right? In school, we learned all these models, biopsychosocial, all the way down through social learning. There is a lot of evidence that there is a contribution of family dynamics in addiction. This is how families cope, okay? And we do see that in transgenerational, right? But I just want to kind of remind you of what we learned. That's kind of what we learned. The disease model, I think people are realizing that there are elements of the disease model of addiction that are absolutely valuable, but I think that we're kind of moving away from it as the sole explanation for addiction. But there are definitely neurochemical changes in the brain, and there's definitely our neurochemical susceptibility to addiction. There's no doubt about that. One of the things I wanted to look at real quick was, these are really kind of low numbers, but it's one of the more recent studies. The comorbidity between AOD and personality disorder is fairly high. It ranges from 44 to 79%, and those numbers tend to be a little bit on the lower end. There are some folks who've tried to study, do specific personality disorders, the old Axis 2, are they related to certain substances? So do we have narcissists going after, cocaine? I don't know if that's helpful or not, but it's out there. Now, what I do think is good, and what we're trying to do at Sovereign, within the parameters of insurance, is we're starting to identify the personality disorders. We're trying to understand, and I have a whole other presentation on that, what is it about personality, I'm going to use the word pathology, that either contributes to the cause, but more importantly, definitely maintains the addiction, okay? Because there is, you can't ignore this comorbidity. It's way too high. It's way too high. So, I do a presentation on, for lawyers on the rate of personality disorders among lawyers, and it's like astronomical. And I say, guys, it's the elephant in the room. You guys are really weird. We just can't pretend this doesn't occur. But for us as therapists, I think it's important to understand that the personality disorder, we may get folks sober for a while, and the milieu may help keep them sober, but unless we're able to do some kind of education or treatment around this, the chance for a long-term sobriety isn't really that great. That's why we have such high, I think that's why we have such high relapsing. The structure's not changing, and of course insurance doesn't want to pay for what it would take to actually do that. I do think that the self-medicating hypothesis is a valuable one. It talks about predisposition to addiction, kind of the disease model, and it talks about that you and I may be equally predisposed. You may be brothers and sisters from an alcoholic family, but I then go and live in an environment where it's trauma-free, the desert, and you may stay in Brooklyn, and where there's much more trauma, so your predisposition gets triggered. All right, so there's something about that. Again, does the drug of choice, if I don't have, serotonin and dopamine, if I have a deficit, am I going to go for something that's going to relieve me? Am I going to be more of a cocaine addict? Or, is there something about that? I think this is interesting. I don't know that it takes us anywhere, but I just want to put out there that it is in the research. Now, I want to go from hypothesis testing to alcohol and substance abuse addiction to personality disorder. And the reason why I'm choosing BPD is because it's the most studied with alcohol and other drug addictions. And it also looks very similar to like a compendium of several other personality disorders. So it's kind of like not a garbage can, but it's kind of a collage, if you will. I do want to say that DSM-5, there was a movement to stop calling it borderline. A lot of folks think that that's very pejorative, and instead talk about it for what its behavioral manifestations are, which is really emotional dysregulation. Psychiatry did not like that, and they kept it at BPD. Now, BPD, those of us who've treated folks who have BPD just know the drama, right? Very, very unstable relationships, distorted self-perception, they're all over the place. So distortion in alcoholism, distortion in self-perception, here you go. Unstable relationship, well, for the hour they have you are the unstable relationship. It's you, all right, in all your glory. You're just doing your thing. They ain't seen it that way because that's their distortion. They're bringing that into the therapy, right? They're manipulative, dependent, dramatic. If you've ever been asked, when I was first starting years and years ago as a student, and I got asked to the prom, and of course I said no. I knew that we're not supposed to do that. And this girl threw the trash can across my room. That was my first borderline experience, that perceived rejection. And I'm sure we've all had that where they slam the door and call us every name but a child of God. All right. So one of the hallmarks is fear. Folks who have BPD they fear abandonment. It's real or perceived, but they fear abandonment. All right? Alcohol and drugs, they can either sedate or elevate that fear. All right? So you see that this, the alcohol and the BPD are kind of going to start to work together because it's fear. Fear. And if you recall, the Freudian, it's death, it's fear, it's sex. Those are the three primaries. And fear, and so what is the fear? The fear typically, again, from a psychodynamic, is annihilation. Just put on your psychodynamic hat for a second. It's the fear that I'm going to be subsumed, psychologically, emotionally, abandoned, okay? Now, if any of you were sitting in here, and we've all had our moments of fear, what eventually got you out of the fear was your sense of self that you could survive. But we just talked about these are folks who have no sense of that. What they can do, and I know you all do this at some point, you say to yourself, my God, you survived all this crap you've done and you're still alive. Our patients are survivors. They have figured out a way to survive, probably better than we could in a similar situation. They have survived, all right? But there's this fear. There's this fear. And you guys know we're not supposed to remove a defense without putting something in place. So we can't just cure the fear unless there's something else we have to give them. All right? BPD, the classic is what causes it. We can't take it out of the brain and excise it. But we do tend to see histories of trauma. What's really key here is the perception. All right, because you have patients where you try to dig out, and I know we've done this, and you're trying to, what was the trauma? This person had a trauma. They had a trauma. It's not always a real trauma. It's a perception. And when you start to get the distortion that they suffered this trauma that didn't really exist in reality, but it's their distortion, that's very, very well ingrained, that they've grown up with that somehow. And we, as therapists, we often, when we work with kids, we'll try to convince the kid whose parents are divorcing that it's not their fault. Your mommy and daddy still love you. You didn't do anything wrong. Well, yeah, but the kid still has that perception that somehow they could have done more or they could have done something differently to not allow this to occur. So perceived distortions, they're pretty basic. They go way back in development, right? There are hereditary factors, and there are some neurological. This is where this science is going. Are there neurological studies that we can point to that says the person with BPD's brain chemistry and brain functioning is different? Probably there is. Now, you guys know this. The one thing that's really important here is the difficulty maintaining relationships. So you're treating an alcoholic who likely has some kind of a personality disorder, probably something on the continuum of BPD, and you say to them, it's important that you go to the roundup because those roundups are really important. That's where you're going to socialize. And of course, they're like, well, I'm not like them. I hate those 12-step meetings. So the very thing that we're starting to hang our therapeutic hat on, the transference between me and the patient and the fellowship meetings, are the very things they can't do. We've also earlier said that their cognitive functioning is somewhat interfered with. So a lot of our treatment approaches are going to be, a challenge. They're going to play into weaknesses that the patients have. All right, and then BPD, they do act, the self-injurious, but it's usually the hysteria. So we had a girl who told us she was going to kill herself, and she was like out front with a rock, and she was smashing her wrist, and we're like, you need to like move up a little higher if you're going to kill yourself with a rock. You're not going to die, smashing your wrist. But it was all drama, and so folks with BPD engage in a lot of hysteria. Okay, now what do you conceptualize hysteria to be? Do you think it's catharsis? Do you think it's distortion? Because depending upon how you conceptualize that, you're either going to let it go or you're going to try to address it as a distortion. All right? BPD, this is the one I think that's the saddest when you get an older person who just doesn't have a sense of who they are. That's sad to me. I mean, that's when kind of my own countertransference comes up, and I'm like, wow, you're lost. You're just kind of a lost puppy out there. You know, you're 45 years old and you just don't know who you are. You know, but that's a real, that's that narcissistic hole, that big narcissistic injury. All right? The anger displays, one of the things we have to look at is, and we try to do a quick neuropsych screen, like a MoCA or something, is there an executive functioning deficit? You know, before we start treating this as purely psychiatric or psychological, is there a more of a neurological component to the acting out behavior? You guys know this on BPD, it's just a refresher. All the relationships that folks with emotional dysregulation, all the relationships that they kind of ruin. And you've got a lot of catastrophizing. These are the folks who are continually going out. You have to send them out a lot, okay? And you know, I think it's always interesting if a patient is intact to go through this suicidal intent and act and just ask them about it. You know, what was going on? Why did you choose that? I always find it really interesting when, remember, these folks are making choices. So why did you choose a rock versus, you know, hanging yourself? Tell me the thought that went through. Was there a planfulness? Was it impulse? Because everything everybody does is a choice. It goes back to our very beginning. Why did you choose to do what you do? Why do we as therapists choose to act in this way or that way? Our patients are making choices, you know? I always think that people who AMA, who leave our facilities but come back, I mean, that's always interesting to me, to say, what are you coming back for? Hell, you were on 10, you know? And if they say, oh, you know, and we all know, 3 hots and a cot. Well, that's important information because that's Maslow 1, you know? So that tells you who you're dealing with. You're dealing with a 40-year-old or a 38-year-old who's at Maslow stage 1. So then you take that information and you say, now how am I going to treat a 35-year-old in my therapy, in my transference relationship, who really is basically, you know, stage, you know, embryo in Winnicott? Because that's what we're doing. Now, we can't approach that with a cognitive approach. It's going to way over their head. But it's important to know what we're dealing with. So I love the AMAs that come back because they've got a story to tell. I also like to think, and in the therapy, I think it's very important in the transference to call the transference out and to say, well, you left. What do you think I felt about that? What was it like for me to sit in the office waiting for you? You know, how did I feel? I think it's really important, and if they can bite on that, then you've got a little bit of an attachment, you know, and it's important to kind of test that. But I think it's very appropriate to do that, to call the transference into the present. You know? Now, what I do think is really cool, really interesting, is how BPD and addiction overlap. This one here, the significant disregard for personal health and safety. That's like Maslow 2. That they will sacrifice their own body integrity, let alone their psychological integrity, in order to, whatever it is, in order to get a goal, which we already talked about earlier was probably a negative goal, or to discharge affect. Okay, I think this one is the one that hopefully we get to this first in the therapy to keep them safe. This is pretty much typically our first goal. But I do think that's really interesting how there's so much, you know, pathological or destructive overlapping there. In your office, for those of us who are therapists, the transference with somebody who has emotional dysregulation is enormous. You can't do enough. You didn't do this. You let them down. And you need to be, you know, strong enough to handle that. You need to check your countertransference, right? But that's the reality. You're going to be blamed. You're the next one, okay? And you need to work the transference. No disrespect to those of you guys who are young, but this is where expertise and experience comes into play. Those of us who've been around the block, we know how to work the transference. We're not scared by it. We can call it out. the first time when the transference comes to you for the first time, replete in all its glory, it can be really scary because you just don't know what to do. How do you respond to it? You don't care for me. Oh, yes, I do. Yes, I do. Is that going to be helpful? I don't know. But, for those who, as you get more experience in this field, the transference is really, really key. Now, one of the things I always tell my residents is, if nothing else, you don't know what else to say, all right, take your countertransference and bring it out. And if you're feeling frustrated, say to the patient, wow, this must be really frustrating, huh? All right? And they'll bite that. They'll respond to that because there's an old maxim, goes way back, that says effect reflects intent. The effect that you're having, that's being presented to you, that you're experiencing, the effect was the intent of the patient. So if you're exhausted, it's likely the patient is either wanting you to be exhausted or he or herself is feeling exhausted. If you're frustrated, it's likely the manifestation of their frustration. Okay? So go with that one. Effect reflects intent. Always bring it out if you're just stuck. It's always a good thing to do. All right. I do want to run through, I'm not an expert in DBT. I do use it. You guys probably know Marsha Linehan, late teens in New York, 2 years in a psych hospital. They think she's schizophrenic. They dope her up. It's Thorazine days. And, she's no better. Somehow she emerges and is starting to do self-help groups and is working with girls. And they're all self-injurious girls. Really, really, really severe. Really severe. And, of course, they say to her, you don't know what this is like. How could you? And she opens up her sleeves and shows all her scars. And says, oh, but I do know. I've been there. Sentinel event for her. She goes to school, finishes her doctorate, and develops this whole theory on used primarily for suicidal females. That was her whole intent, to really help the women that she could totally relate to. Now, why this is beautiful is the two poles. Sometimes people say, well, why is it dialectical? The two poles are acceptance, very Rogerian, very Adlerian, yet change. It's so important in DBT to accept the person's experience. No matter how distorted it is, in the beginning, we accept it. And we don't approve it, and she's very, very clear about that. You don't approve it. Acceptance is not approval. But it's the ability to say, wow, I can understand how you got here. Your story, I can understand it. Even if it's a delusion. Because the last thing we do with delusions, you guys all know this if you work with demented people, you never refute a delusion. You can walk into it with them and you kind of, prance around and, gradually you bring them out of it. All right, so we don't refute people, we're accepting. But we know in the back of our mind, because we wrote our treatment plan 15 slides ago, that we're going to eventually introduce change. But we start with the acceptance, okay? Really important. And what I like is it involves, and the reds are the things you've seen already. It addresses the psychological causes of addiction. It talks about learning new skills. If you've ever done DBT and you do the little chaining and you ask people to write all the steps down that led them to this behavior, and then you ask them, wow, you found yourself living in a box. Let's go back through your chain. When could you have intervened? How would you do things differently? A little bit of a cognitive approach. All right. The other thing I like really about DBT, for those of us who work in milieu, very important. The recovery agreements, the whatever we're calling them, behavior agreements, when a person screws up, you got to make them manageable for the patient. So I see these, I don't see them as much in my job now, but I'll look and I'll just read some of them and I'm like, wow, you want this person not to drink for a week? Are you kidding me? He's been drinking for 40 years. Why don't we get through the shift? Now that's a lot of work. Listen, I know it's a lot of work, but the goals in DBT have got to be manageable recovery goals. We talk about, one day at a time. Sometimes it's one shift at a time or one half of a shift. If you're dealing with reactive attachment disorder children, you know this. If you can get through an hour with some of those children without harming themselves or acting out, you're doing well. But in our programming, I'm just going to tell you this. If you have to develop the skill set, but especially the staffing to do these manageable goals, that a person can have success. And the other thing about it, and you guys know this, is we're not supposed to just throw them a behavior contract, make them sign it, and then forget it. It's got to be a therapeutic, experience for them. What's it like to have made it through this shift, without telling somebody to, go to hell? We've got, because we're teaching them new behaviors. So the whole, behavior contract recovery agreement needs to be part of a treatment modality. But I just think making it manageable is crucial. I see these things where they're not going to, curse for a week. Are you kidding me? That's just not setting somebody up for failure. It's never going to happen. All right. We know that in DBT, we're looking at mindfulness. Mindfulness, remember mindfulness, not meditation. We don't close our eyes and do, It's not mindfulness. What is mindfulness? Mindfulness is the ability to sit with the very affect that you normally would be running away from. And what we want to do is we want to teach people that it's okay to feel sad or angry. I don't have to medicate it. Think about the last time you had a blistering, if you've ever had a blistering argument with someone you love, spouse, partner, family member. How long did it take you before you made an action? Either called your best friend or, put on the TV. How long were you able to sit with that affect before you decided I got to get away from it? All right, because we've all had that experience where we self-medicate in different ways. And in DBT, we're trying to get people to sit with it. So a lot of times, and this is beautiful, in psychotherapy, if you do the mindfulness, one of the things they're going to feel is boredom. This is boring. And you say, I can just sit with it. Because boredom, as you guys all know from the old HALT model, right, is one of the triggers for a lot of folks. They can't handle the lack of stimulation. So they go to get rid of it. But in your therapy, it's not a bad idea to let them sit with the boredom and then to say to them, wow, what was it like for you to be bored and sober? What was it like for you? Oh, I thought it would never end. Like right now, some of you guys are saying, 7:30 is not done yet. Oh my God, but seriously, you're containing your affect right now. You're doing it. You're sitting with it. That's really an important skill to teach our patients because it's what they've run away from this their entire lives. It goes back to that self-medicating hypothesis. This stuff kind of all ties together eventually. All right. So I'm not going to go through all of this. Again, I'll give you a website or an email address to get it, the presentation. But again, we don't want judging going on. There's no judging. Right? We're not judge and jury and all that jazz. We're not judges of their experience. All right? We're trying to teach interpersonal relationship skills. That's a little bit more cognitive. And this is the key. And I bet this is the key for a lot of us in this room. How do we sit with the feelings that trouble us, that we don't like? How do we sit with boredom? How do we sit with loneliness? How do we sit with emptiness? You ask a sex addict, they're going to tell you there's so much emptiness and loneliness in their experience. And they go into these episodes to distract themselves from that. All right? Distress tolerance. Now, you guys right now are delaying gratification. You're hanging in. You're hanging in there, right? So it can be done. You're an example of it. Right? I keep on thinking about it. I was saying to myself, what time is that little party in Palm? Is there like a big thing in Palm Springs on Thursday nights where there's like fires in the street or something? Yeah. I was like, I want to get to that thing, 7:30. And I was like, and then I said, well, it's fires at night, so it's got to be at night. So we got plenty of time. Anyway, so when you look at dialectical behavioral therapy for emotional regulation, this is the chaining. This is a really, really good activity, even if you're not doing full DBT, to ask the patient to take an event that they're not very happy about that they did, and take them through the cognitive steps. Where were you? What did you do? What all the steps? Because you're going to be amazed. This goes back to their survival skills. When pressed, these folks can put together a pretty good plan, a pretty good chain of events. And it's neat to say to them, well, geez, at the end of the day, it wasn't a very good response or effect. Where would you have done something differently? You know, it's an interesting activity. So what did we do? Almost 7:30. We talked about how to develop a hypothesis, what are change theories in the research, what are alcohol and other drug addiction theories. We looked at the BPD and then the overlap, and we talked a little bit about DBT as an intervention. Now, what I want to do for the next hour is, oh, laughing, right. This is if you would like a copy of the handout. I didn't want to kill trees here in California. East Coast, I'll be giving you 10 copies each. But this is the email of our assistant who can just say we met in Palm Desert. Can I have a copy of this talk? Thank you guys. I really appreciate your time.